Welcome to the webinar, Workplace Health Disparities, the Total Worker Health Perspective. My name is Sarah Mitchell, and it's my pleasure to serve as the moderator for today's webinar. On behalf of the NIOSH Total Worker Health Program, we're delighted to have you with us today. Today's featured presenters are Constance Franklin, Michael Flynn, and Dr. Kendra Jason. Constance Franklin has worked in the area of diversity at CDC and NIOSH for the past 20 years. Her focus has been on health equity, health disparities, health outcomes, and diversity in the workplace and within the workforce. Constance served as the chair for the NIOSH Diversity Steering Council for over 15 years. In addition, she has been the co-lead for the Healthiest NIOSH program, NIOSH's internal Total Worker Health program, for 12 years. This program focuses on improving the health and well-being of all of those working at NIOSH through the adoption of programs, policies, and practices. Michael Flynn is an applied anthropologist with over 25 years of working on issues related to diversity, equity, and inclusion, both domestically and abroad. His interests include organizational culture change, translation research, and social determinants of health. He currently serves as a lead social scientist with the National Institute for Occupational Safety and Health, where he coordinates the Occupational Health Equity Program. He is also the project officer for a program of research to better understand and improve occupational health of immigrant workers. He is a research fellow at the Consortium for Multicultural Psychology Research at Michigan State University and a member of Ventanas de Salud National Advisory Board, a program of the Ministries of Health and Foreign Affairs of Mexico. He has a master's degree in anthropology from the University of Cincinnati and is currently pursuing a PhD in anthropology at the University of Kentucky. Dr. Kendra Jason is an assistant professor of sociology at the University of North Carolina at Charlotte. She is an interdisciplinary health disparities scholar who examines the multi-level factors that may influence the relationship between health and desired workforce participation for older Black workers. She seeks to identify contributing factors for health disparities by analyzing the links between race, discrimination, workforce behaviors, and care processes. Her research on these issues are published in the Gerontologist, Journal of Applied Gerontology, Healthcare Management Review, and Research in the Psychology of Work. Most recently, her work was featured on Forbes.com and PBS Next Avenue. So welcome to all of our featured presenters. Now we will begin with Constance Franklin.
Thank you, Sarah, for that introduction. And today I hope that I'm able to get across to you why diversity matters for total worker health. This is our outline. We will discuss a little bit about total worker health, Healthiest NIOSH, and workplace disparities. We'll talk about some examples of workplace barriers to worker well-being, what is the NIOSH Blueprint in Action, and how the NIOSH Blueprint in Action addresses equity and worker well-being. So what is total worker health? Total worker health is practices that integrate protection from work-related safety and health hazards with the promotion of injury and illness prevention efforts. It's a strategy integrating protection and prevention. When we think about total worker health, we have goals here of keeping workers safe and establishing workplace policies, practice, and programs that grow health to create worker well-being. If you take a look at this puzzle, you can see that all of these areas related to the workplace are together like a completed puzzle. And this is the goal here. We want to eliminate silos in these little pockets where everyone's working independently and work together to improve worker well-being. So when you think about the organization of someone's work, the change of the working demographics, getting your leadership on board, all these pieces of the puzzle are integral in improving worker well-being. This is the hierarchy of controls applied to NIOSH, the Total Worker Health hierarchy of controls. And if you look at the very bottom, the brown tip of the hierarchy talks about encourage personal change. This is the absolute bare minimum thing that an employer can do, is encourage their employees to make personal changes to improve their overall well-being. But I really wanted to have you take a look at higher up in the chain, in the chart, because when we think about how we can improve worker well-being, things like educating our workers is important, redesigning the work environment for safety, health, and well-being, substituting health enhancing policies, programs, and practices, and eliminating the working conditions that threaten safety, health, and well-being altogether in the first place. This integrated approach, this is all what we think about when we're talking about links across the systems. What contributes to the worker well-being, the safety and health folks at the table, human resources people at the table, employee benefits are also a part of the puzzle to make this integrated approach work. And how do you design an integrated approach? Well, your organization's policies, programs are important. The psycho and social environment, physical, and psychosocial environment is also important, as well as individual supports. These are some total worker health policies, programs, and practices that we recommend, but I want to draw your attention to a couple of them. For example, paid family and sick leave and paid medical benefits. Most of us on this webinar probably don't think twice about whether or not we have paid family and sick leave or medical benefits, but some people are dealing with this issue when it comes to taking off for work if they're feeling ill. In addition to wages, staff involve overtime. There are people in the workforce who are not getting paid a living wage, who are working under very stressful work situations because there's not enough staffing. And then there are people being forced to work overtime. And even we've heard cases of people who are not getting properly compensated for that overtime. In addition, many of us may consider our workplaces to be free of discrimination, harassment, and violence, but that is not the case for everyone. These are just a couple of the things that I wanted to pull out of this list to bring forward that relate to health disparities in workplace. Now, Healthiest NIOSH is our internal program that focuses on the safety, health, and well-being of all the people working at NIOSH. And we try to do this by looking at our workplace environment, policies and programs, and increasing the number of health opportunities available to our staff. And as we grow and evolve, we share these interventions throughout the agency and with many of you. This chart here, the issues relevant to advancing worker well-being, breaks down these categories in many different ways, but I want to draw your attention to workforce demographics and the categories under there: diversity and inclusivity, multi-generational folks in the workforce, productive aging across the life course, vulnerable workers, and workers with disabilities. These are often areas where we see health disparities in the workplace. Now take a look at this colorful slide here that just kind of highlights some of the issues that happen when there are disparities in the workplace, with anxiety, and there's depression, unconscious bias. People are dealing with institutional racism, systemic racism, battle and fatigue. These are just some of the many things that float to the top when we're talking about issues affecting diverse workers. Again, take a look at this slide and you'll see occupational segregation is an issue where people are segregated by their occupation and sort of held in a category of not being able to move forward in an organization. Your wage inequality and the wealth gap, where people are not being paid livable wages, but often doing the same job as other counterparts, but not being paid the same amount, which contributes again to the wealth gap across the world. Occupational racism and mental health outcomes. This is one big one because there are many issues that people are dealing with that are mental health related from their workplaces, whether it's stress, whether it's fatigue, whether it's anxiety. These are very real issues that people are facing in their different workplaces. Diversity, inclusion, and equity, advocacy, and visibility. This is something that is very important when people feel like they're seen and heard and included at the table, have an advocate when it comes to their workplace. These are things that are important and make people improve their worker well-being when they feel like they have a voice and that they are heard in the workplace. Now, what is NIOSH doing in terms of dealing with diversity in the workplace? We have a blueprint in action, and the blueprint in action is a new strategic plan that is designed to help NIOSH take action and institute as well as to create greater diversity and inclusion in its workforce, workplace, and the marketplace, and to fully integrate diversity and inclusion into the service, the public. There are 3 areas that we do have some strategic goals around improving diversity and inclusion with respect to workforce, workplace, the marketplace. So what does the workforce look like at NIOSH and how do we improve it? What is our workplace like? What is happening in the actual workplace, in the different locations and buildings and offices, our work environment, and the marketplace? We also have a diversity and inclusion office, and the diversity and inclusion office is here to promote diversity, equity, and inclusion in the NIOSH workforce, the workplace, and to its research and services. And we have some core areas that we focus on in this diversity and inclusion office that include strengthening and diversity recruitment, making sure that we are reaching out to populations that may not be as familiar with occupational safety and health. We are helping to create measures, strategies, and systems to remove barriers to diversity and equity and inclusion at the Institute, tracking and assessing, communicating diversity and equity, inclusion-related progress and milestones, building capacity for self, social, and community awareness of bias and other barriers to diversity, creating a dialogue where people can speak safely and freely about any issues that might be occurring in the workplace, advocating to increase access to educational and research professional opportunities at NIOSH. We fund many institutions of higher education, so taking a look at those areas, as well as encouraging transparency around policies, efforts, and issues, cultivating affinity groups and affinity spaces, and helping to build internal and external partnerships to support the advancement of diversity, equity, and inclusion at NIOSH. Now, this wheel, the worker well-being wheel, really puts all the pieces of the puzzle together when we're talking about your worker well-being, with workplace, physical environment, and the safety climate, workplace policies and culture, the health status of your workers, and work evaluation and experience. When you keep worker well-being at the forefront, um, these are issues that will affect your worker and how you can enhance their worker well-being. And so we've seen this over the past 15, 16 months here with the pandemic, where worker well-being has been at the center of many conversations. We've talked about the fatigue and the level of stress of the healthcare workers in the hospitals, the safety of our educators returning to their classrooms and what that means for their well-being. And then let's not forget about the retail workers and grocery workers who've been providing our basic needs this whole time. Our grocery stores, all those things have been open and available to us, and the risk of those people working during this time. And then there are many people who've lost their jobs or had their hours cut during this time, who would be many of those are low wage workers or vulnerable workers who may or may not be making a livable wage already before the pandemic hit. And all of these factors that affect and contribute into the workplace, keeping the worker well-being, keeping your worker well-being as the focus of your workplace policies, programs, and practices is key in minimizing and eliminating workplace health disparities. Thank you.
Okay, good afternoon, everyone. My name is Michael Flynn. I coordinate the Occupational Health Equity Program here at NIOSH, and I'm going to talk a little bit today about the relationship between work health equity and the role that plays in this larger paradigm shift towards a biopsychosocial paradigm in occupational safety and health. Well, there we go. So, occupational safety and health has largely developed into a technical field that focuses on identifying and eliminating workplace hazards. And it's based largely on the biomedical model of health that tends to focus on a specific cause and of a illness or injury, and then try and eliminate it. However, the restructuring of work in terms of industries, jobs, and technology, the growing recognition of diversity in the workforce and the importance of health equity, as well as the broadening understanding of the relationship between work and health, which underlies much of the total worker health model, have all challenged this current paradigm and suggested the need to expand and complement the reductionist view of cause and effect in the biomedical model to incorporate the social, political, and economic context that contributes to health outcomes. In short, we need to move towards a biopsychosocial approach to occupational safety and health. And there's a link to a blog there that we wrote about that. When we talk about the biomedical model really focuses, it's the predominant model in Western medicine, and it focuses on the physical processes that affect health, such as biochemistry, physiology, and pathology. This model tends to be fairly reductionist and focused on one underlying cause. The goal then is to eliminate that underlying cause and return the person to health. Social medicine, on the other hand, studies how social and economic conditions affect health, disease, and the practice of medicine. This was developed in response to the increased levels of disease and poverty among workers in the Industrial Revolution, most notably pioneered by Rudolf Virchow in the mid-1800s. And not only is Virchow seen as the father of social medicine, but also I think because his work dealt so much with how the work at miners had and connecting that to the typhus epidemic that they were encountering. I think he holds a special place for the total worker health program as well. And so really the biopsychosocial approach tries to complement the biomedical model by adding elements of psychology and social medicine and to explore the dynamic multi-directional interactions between biological phenomenon, psychological factors, and the social relationships and contexts which impact health and well-being of individuals over the life course. Central to this model are the social determinants of health. Now, while there are many social determinants of health, the ones I think that are most relevant to occupational health are three large buckets, right? First, how we structure society along social axes such as race, ethnicity, class, gender, nativity, etc., right? How we structure society, how we structure industries and organizations in terms of things like the competitive bidding process, the externalization of risks from larger companies to smaller ones, and different subcontracting practices, and how we structure jobs in terms of employment arrangement, shift work, autonomy, etc., all impact the distribution of work-related benefits and risks. Now, the Occupational Health Equity Program tends to focus on this first bucket in terms of society and social axes. But as we know from the Overlapping Vulnerabilities report we did a few years ago, we know that disadvantage often clumps. And so disadvantaged groups within society are also find themselves in disadvantaged situations in terms of industries and organizations as well as jobs. And so it's important to take an intersectional approach or see these things together and not isolate them in silos. So the mission of the Health Equity Program is to promote research, outreach, and prevention activities that reduce avoidable differences in workplace injury and illness that are closely linked with social, economic, and environmental disadvantage. A central challenge to securing health equity, however, is that the same social structures that contribute to health inequities also operate and are reproduced by public health organizations. What do we mean by this? Basically, in other words, safety and health organizations have evolved to better meet the needs of some groups more than others. One way this plays out is that those who are most in need of preventive interventions are least likely to receive them, or what's known as the inverse equity hypothesis. And an article here that's highlighted, we wrote, has to deal with the difference between those that are labeled as hard to reach versus those being hardly reached. And so basically the way we've designed from the perspective of the normative group, interventions or outreach campaigns and partnerships often excludes many groups of workers who are in more need of these services, right? Another way this plays out is through intervention generated inequalities, right? Which aggravate inequalities when they disproportionately help members of less disadvantaged groups. And so when we design interventions for the normative group, right, those not in that group, often those interventions don't work as effectively with folks from different groups, different social groups. So when we're talking about the dynamics of diversity, where we're talking about something, we need to understand this as more than just differences. We need a conceptual model that addresses the asymmetrical power relationships along social axes such as race, ethnicity, class, nativity, that contribute to the inequitable distribution of resources, injury, illness, and health. In short, we need a model that accounts for power and privilege. We need a model that understands these as institutional relationships, not personal flaws. These power relationships are embedded in social structures, and where you stand or your social position within these structures impacts what and how you understand these dynamics. The goal, therefore, is not to try and remove yourself from the social structures, but to recognize these power dynamics and work to change the arrangements towards a more equitable, to put them on a more equitable footing, right? However, some perspectives are endorsed as the norm by social structures and are sanctioned or reinforced by media laws and institutional practices. One of the issues here is that privilege is often unacknowledged and understudied. So most of the focus we have is on the group that has the disparities, and often we don't turn the analytical lens back on the institutions and the groups in power to understand how they're privileged and benefiting differentially from the system. There are three key areas of interest that the Occupational Health Equity Program works on. The first is targeted research that focuses on particular health inequities for workers. Three main areas within this are: one, your standard epidemiology, which is identifying which workers are at increased risk. The second attempts to explain how structural disadvantages materialize in the lives of workers that then contribute to their increased risk. So for example, the article here discusses how undocumented status is a social determinant of occupational safety and health, right? And then finally, how do we take that knowledge to develop and evaluate interventions to address those disparities? The current limitations of this work is that research on technical aspects of OSH has historically been favored over that which explores the social context that circumscribe occupational safety and health outcomes. This longstanding imbalance has led to research questions, funding decisions, data collection instruments, and scientific assumptions that are tailored to understand the normative group, which all fits into the larger trend of what Paul Farmer calls the desocialization of scientific inquiry, or the tendency to ask only biological questions about what in fact are biosocial phenomena. So the next steps in this area are: one, we need to prioritize projects that target occupational health inequities, right? We also need to increase the involvement of social science in occupational safety and health. This can be through direct hires of anthropologists, sociologists, et cetera, through collaborations with people in other departments, and also by foregrounding this social perspective by putting social scientists in internal leadership positions and incorporating them as external advisors. I think total worker health plays a particular role as a bridge here, because to selling occupational safety and health, this idea of the relationship between work and health, I think would be very attractive and salient to many people in the social sciences, in a way of really bringing them to OSH as a field. The second key area of work that the Health Equity Program does at NIOSH is attempts to integrate an equity perspective across occupational safety and health as a field. The current dynamic or paradigm is that equity research is currently the domain of individual standard bearers. And so what we need is really a culture shift to move concern for health equity from that of a model based on the individual concern of specific researchers to an institutionalized practice that is embedded in all of the work that we do. This doesn't mean that all research needs to be focused on equity, but all research needs to account, at least at a minimum, for the diversity in the workforce and how social determinants impact or potentially impact the distribution of the benefits and risks of work. Right? Inclusion, of course, is not just an ethical issue, but it makes for better science. Some barriers to inclusive research, three general buckets I like to think of are: first is structural invisibility. Basically, we can't see we can't fix what we don't see. And so there are severe limitations in the collection, analysis, and publication of social determinants of health data in occupational safety and health research. This, of course, impacts future research and interventions and funding and the direction of the field. A second key area is institutionalized exclusion. This can take the form of exclusionary scientific assumptions, such as the 80-kilogram man, or gender bias in exoskeleton development where exoskeletons are designed for the male body frame and not the female body frame. These can also take place in terms of recruiting methods, like I mentioned earlier, in the hard to reach versus hardly reached. And so not only do we have to ensure that the recruitment methods are incorporating workers from a variety of different social backgrounds. But when we call them hard to reach, we're almost blaming that group for not, there's something about that group that makes them difficult to reach. When we frame the issue as hardly reached, we're turning the lens back on the institutions, and the question isn't, what is it about that group that makes them hard to reach? But rather, we have to ask, what is it about our institutions that we haven't developed the capacity to effectively work with a variety of groups out there, right? Then the third key area is unconscious bias. And I think, Constance mentioned this earlier, and a key way unconscious bias is understood is in terms of how some groups relate to, how individuals relate to one another. But unconscious bias also impacts the research questions and approaches that we have, that we bring to our work, and also the assumptions in the way we understand the items, for example, in surveys. And so we wrote an article here that's highlighted about the assumptions within, how the understanding of emotional health was understood differently by the researchers and Latino immigrant respondents. And so we have to be sure that we're checking what those unconscious biases or assumptions we're bringing to the research are. In terms of next steps in this area, one, we need to identify and address these barriers to ensure, these exclusionary practices, right? We need to work on institutionalizing the social determinants of health and health equity approach into the institutions in the field overall. A central way to do this is to address the social location of the researchers and practitioners. What is the cultural perspectives they're bringing to the work, not just of the cultural perspectives of the people being reached, right? And we need to develop ethical partnerships that include, to complement these social positions with, institutions actually in the different communities that the workers are coming from. And the third key area, which is probably the most relevant for total worker health, is promoting work and the relationship between work and health inequities writ large in public health. So we know that work has long been acknowledged as a social determinant of health in public health. However, the non-work related conceptualization of hazards and outcomes has historically separated occupational safety and health from the rest of public health. But we know that work is not only a social determinant of health, but it's a fundamental mechanism that controls other social determinants of health. Work circumscribes, to a large part an individual's life. It determines, what time they wake up, when they go to bed, how much time they have to spend with their family, the type of neighborhood they live in, the income they have, the types of schools their children go to. So work really has a significant and oversized impact in determining or circumscribing the physical, emotional, and social life of the individual and their family members and dependents, right? As such, it also impacts other social determinants of health, as I mentioned earlier, such as income, education, social status, and other things. And so really, we like to consider work as a fundamental mechanism for, pushing towards equity and addressing social determinants of health. That being said, work remains largely absent from health inequities research in public health overall. One of the activities we're currently doing through the Health Equity Program is to review key public health data systems to determine the degree to which they incorporate items related to work, that they're asking people about. And this is detailed in the journal article that's highlighted here. So when we look at the relationship between work and public health, that I think underpins much of what total worker health is all about. Looking first to work as a health promotion site. So this is the classic, smoking cessation or promoting exercise at the workplace. I think we can also see, however, work as a social location to address other social determinants of health and social inequalities, right? And so by increasing the wages of workers, by increasing access to time off, sick leave, et cetera, we impact not only the well-being of those workers, but can also impact the health and well-being of their families and communities. When we see work as a social location, to address these social determinants, it allows us to enter the discussions around job quality and not just job quantities. You know, what is it about good jobs? And what's the difference between a good job and just a job? And how does that impact health overall? In other words, what we're saying is that labor policy can be considered or understood in many ways as health policy. And by doing this, it allows us to connect public health with development initiatives. And so, like the article that's highlighted here, discusses, taking on the decent work agenda from the International Labor Organization allows us, in seeing work as a social determinant of health and engaging in discussions of job quality, not just job quantity, allows us to interact and engage with larger social movements, such as the movement towards sustainability or efforts around corporate responsibility. And it allows us to better find ways on how to integrate public health or discussions of health into those initiatives that are currently underway. And so the next steps in this area of work here is, one, broadening the framing of work, of the relationship between work and health. Occupational health has historically promoted the inclusion of items regarding industry and occupation into public health data collection systems. And I think this work is essential. But we also need to expand that to include other elements of work, such as or underemployment, or job security or satisfaction, and other work-related elements that may be also contributing to the health, to particular health inequities that public health researchers are looking at. We need to reach out to non-traditional fields, such as public health, social sciences, and economic development. Again, I think this is where total worker health and the notion of the relationship between work and health writ large is a key factor in enabling us to reach out to these fields. And finally, we need to promote work as a social location for action. We see in society there's a renewed emphasis on health equity as a result of the pandemic and a growing interest in decent work. And so we need to leverage this moment in time and push forward on that, right? So in conclusion, health equity and total worker health are central elements of the paradigm shift to a biopsychosocial approach to occupational safety and health. This is going to require a culture shift from individual concern among individual researchers and practitioners for social determinants of health and health equity to really institutionalize practices across the field. This work is going to impact not only occupational safety and health as a field, but has the potential of impacting public health overall. And the institutional support we received will determine how quickly and successfully we adapt to this paradigm shift. I think the important thing here is the paradigm shifts are already occurring. The question is, how can we adapt to it, right? Obviously, our program can help with the different total worker health centers who are interested in integrating an equity perspective in the work they're doing. And so really the question we're left is how can we best leverage this moment in terms of institutionalizing a health equity perspective and bridging the gap between occupational safety and health and public health, occupational safety and health and social science. And again, I think total worker health and the relationship between work and health writ large is going to be a key component to that, to bridging those gaps. So with that, I'll thank you very much for your attention and now turn it over to Dr. Kendra Jason for our final presentation of the webinar.
Thank you, Michael and Constance. Really set up my research well here. So let me click to the next screen. All right. So my research is specifically on Black workers, and even more specifically than that, older Black workers with chronic conditions. And today I'll be talking to you about their health, COVID-19, and then ending with some workplace recommendations that actually fold really nicely into the setup that Michael and Constance have for me, have done for me. So I'll talk about what we know, and with my empirical research, I'll tell you some experiences, what are the gaps, and then what are the recommendations. So first, on Black workers in particular, because they disproportionately face challenges in the labor market when it comes to compensation and retirement benefits. So we know that workplace employer benefits are tied to Social Security, right? It's that federal insurance plan pays a monthly monetary assistance to people who are retired. This is calculated by how much time you are in the workforce. Again, pensions, another employer benefit, is calculated by the number of hours, number of years you have in service. And then the 401k plan, which is popular today, is an employer contribution plan that is now the dominant employer health benefit. The unfortunate thing, however, is that, as you can see from this chart here, you have men in green, women in blue from 1979 to 2019, and then all Black Americans with more recent data over the last 20 years, is that Black Americans earn less over the life course in comparison to their white counterparts. And so as their employer health insurance and assistance is tied to the number of hours worked, there's less payout when it comes to retirement. And this wage gap continues to grow. There's a huge misunderstanding, or since civil rights, that there have been so many gains in the labor market, but those gains don't actually equal income advantages for Black Americans. And so what you can see here, again, from 1979 to 2015, that the wage gap between Black and white workers has actually continued to grow. And so, as I said, Black workers earn less over the life course. And so that also means that they have less insurance support in comparison to their white counterparts at an older age. Another significant factor is that the diminishing union activity really decreases, especially Black workers' access to these defined benefits plans. So this is discrimination over the life course, as is evidenced through work. And what we know is that those who face regular discrimination are disproportionately burdened by having multiple chronic conditions. And thus, having those multiple chronic conditions, they face greater challenges with respect to continued employment. So it doesn't matter if the discrimination is real or perceived. Even the perception of discrimination produces stressful circumstances which lead to multiple chronic conditions and affects workers' ability to function in life as in work as well. So when we talk about multiple conditions, Black adults report higher diabetes, hypertension, asthma, arthritis, and obesity, again, in comparison to their white counterparts. And they suffer from more chronic illnesses, have poorer health outcomes, and higher death rates compared to nearly, not all, but nearly all other racial groups, okay? That's physical health, but even considering mental health, older Black adults experience higher depressive symptoms than their white counterparts again. So this is the health disparities in later life. So what does this mean? This means that Black Americans are essentially trapped in a sense, but they must remain in the workforce longer so that they can sustain financial support and keep access to health insurance. Now, this is even further compounded when that individual is a low-wage worker and cannot afford to retire. So in my own personal research, I really want to understand the health and work challenges of a very specific group, older Black workers who are age, but they work in full-time jobs. And they also have multiple chronic conditions, so they have more than one chronic illness. And I really want to understand how the workplace environment can either foster or hinder their ability to keep working, as termed resilience here. And I really want to identify strategies so that they can remain engaged in work for as long as they choose, right? And then as a researcher, I would like to be a liaison, if you will, between the worker and management and the workplace, and recommend interventions and recommendations to help them remain, again, as long as they desire to work. So I'm going to start with this concept of resilience. It's going to be defined a little bit different than what you're used to. So resilience, really comes from education literature on children. Resilience is when an individual successfully adapts to risk and adversity, right? But in my case, when I'm looking at older adults at work, I really think of resilience as the successful management of health challenges while doing hard work. Remember, the people in my study are not just older workers, but they're in low-wage jobs, they have physical jobs, and they have chronic illness. So a lot of hard challenges going on here. So as an example, I say, imagine mopping a college cafeteria with arthritis while feeling dizzy from blood pressure medication, all right? What I want to understand as a sociologist is not what's happening on the individual level when it comes to resilience, as people have studied before, but more so, what are the structural explanations for these workers' resilience? So I'll tell you how I captured, I did a study of about 15 to 20 older Black workers in these low-wage jobs. I'm a qualitative sociologist, so this was captured in my interviews. So this housekeeper with 4 chronic conditions says, I'm the type of person that if given a task, I'm going to get it done, and I'm going to do it to the best of my ability. It doesn't affect my job for the most part in a negative way. It affects me because I push myself harder to push through it. So that's just harder on me. Another way that I captured resilience was from another housekeeper, 55 years of age, and she says, I just go right on, keep on rolling. And of course, this is in conversation when asking her about how is she able to, continue to work despite the physical illnesses that she has as a housekeeper. So one of the strategies that emerged from the data is that these workers were able to manage their health by finding a preferred employer, okay? This was actually one of the most important factors when managing their health. So a preferred employer, in short, is an organization or workplace in your community that typically pays higher wages, and in this case, even for low-skilled work, and offers full benefits at a lower out-of-pocket cost than their previous workplaces. So the people in my study, they're housekeepers, they're cashiers, they're janitors and such, and they've been in low-wage jobs their entire life at different workplaces. And a preferred employer is a place where they can get higher wages and afford the healthcare that's offered by their employer. Another way that they were able to manage their health challenges is through scheduling. Okay, this is another institutional norm for this workplace. So typically, this batch of workers, and this batch of workers had a number of titles. They worked Tuesday through Saturday from 5 a.m. to about 2 p.m. And so what this did is just really allow scheduling, so they did not have to take time off to make doctor's appointments or to take care of their health needs. So one interesting thing about this particular workplace is that they were provided consistent scheduling, but it was also inflexible. And I'll tell you what I mean by that in a moment. Another way that these workers manage work, not their health, but their work responsibilities, is by depending on coworkers. So this is a really interesting phenomenon here where these older workers age 50 plus in my study relied on other older coworkers to get their job tasks done if they had to go to work and their arthritis was bothering them, or they they felt dizzy or didn't feel 100% to get a particular task done. In this particular case, they said that younger workers were not really helpful with sharing tasks or alleviating them of the hard work of their physical jobs when necessary. So this stockroom attendant, he's 55 years old, he has 3 chronic conditions, and he says, as if he's talking as if he's one of the young guys. He's saying, a young guy should say, I'm not going to let that old man work hard. You chill out. I got you because I'm young enough. My back's strong enough. I can do that. But then he says, I work harder than the young workers, and I really shouldn't be. So I mentioned before flexible work arrangements. So work arrangements and changing, we always hear about flexible work arrangements as a way to accommodate workers for different reasons. In this particular workplace, there was no light duty, right? And then there were inflexible work schedules. And so as an example here, another housekeeper, 57 years old, she gives the story of one of her coworkers. She says, I know one of my coworkers, she has cataracts, and Mondays, she works from 8 to 5 and it's dark. And she asked the managers if she could, come from 7 to 4 so she could get off before dark because the light bothers her. And they just flat out refused that 1 hour. So even though the consistent scheduling did allow for them to have time to make doctor's appointments and things of that nature, there was no accommodation for light scheduling as they were older and physical with physical ailments or any inflexible or flexible work arrangements. So work essentially was allocated equally across all workers, regardless of age, illness, or physical ability. So stress and work environment was a really interesting theme that came up because it actually had positives and negatives to it, right? So these workers were actually experienced less stress at work when reported that the clients were friendly, they had really compassionate supervisors, they had great camaraderie with their peers, and the work was familiar. So they were a cashier at this particular workplace. They had been a cashier at several workplaces over a number of years. So the work didn't change. But there were also instances in which caused more stress, which also leads to more negative health consequences. The things that caused stress were being short-staffed, so high absenteeism in that particular job. New management often equaled more write-ups. Different managers have different expectations. With new management comes organization system changes. And it's not necessarily that these workers are older and so they're inflexible and can't adapt to change. They can adapt to change. It's just the things that they were doing before are now being penalized when they weren't penalized previously. And so they had to deal with this with new management and new information systems. And another change is more technology in the workplace. And again, this is not to say that older adults cannot adapt to older technology, but it is a difference when before you were doing something by pen and paper or by a analog clock, but now you have to sign in through a computer. And it may be a learning curve with the software as with anyone else who's learning new software. So how did they navigate these risks? And I'm just going to summarize this for you. So they managed their health risks by first finding or seeking a preferred employer. Again, this is an employer with better pay and affordable health coverage. Finding consistency in their schedule. One thing that we know about low-wage work is that there's often inconsistent scheduling, which makes it hard to plan and makes it hard to make appointments for doctor and things of that nature. So the consistency really helped them out. And then another good thing, when I said that they had compassionate supervisors, they reported that when they needed to have time off, or if they needed time off during their work schedule, there was no pushback or, negative sentiment or feelings from the managers. The managers would allow them to have time off without any grievance, and human resource had an open policy for taking time off. So how do they manage their work risk? Remember, this is how they complete their task in spite of the physical ailments that they may have that makes work difficult. One thing is working in teams and building camaraderie. Again, these workers specifically said that in this workplace, the younger workers were not much help, but older workers did build a teamwork model, which helped get their tasks done. Doing familiar work. And then having an enjoyable workplace. So they really enjoyed engaging with the clients and coming in every day. They enjoyed their coworkers. So favorable work environment really helped them navigate and manage the work risks that come with low-wage physical jobs. So these study findings revealed that older workers, even with different social supports, finances, physical limitations, and education, all describe their workplace, the institutional structure when it comes to pay, benefits, and culture, for example, as the primary factors to be successful in the management of their chronic illness while they're doing their jobs, okay? This really goes back to what Mike was saying before about taking this institutional approach to the social determinants of health and how to better meet the needs of workers. So more research needs to be done to address these organizational factors so that, again, these older low-wage workers can work as long as they choose, even with the chronic illnesses that they have. So I just want to talk for a moment about COVID-19, racial injustice or disparities, and then employment precarity. So I use the terms of cashier and stock person and housekeeping. Well, the language of essential worker really was prominent in 2020, of course, due to 2019. I mean, in 2020 due to COVID-19. And so the CDC back in July of last year wrote a report and basically said that racial and ethnic minority groups are disproportionately represented in essential work settings, such as healthcare, facilities, factories, grocery stores, public transportation. And those who work in these settings will have more exposure to the virus that causes COVID-19 due to the fact that they work in close contact with the public and other workers who are not able to work from home and who cannot take advantage of having paid sick days, because typically low-wage work, essential labor jobs are not connected with great health care. And so if you're sick, they often go into work because of the inability to take off for pay. And so there were some reports that came out in 2020 from ARP, the National Employment Law Project, and some other sources that, of course, said among older workers, Blacks and women face higher COVID-19 risks. People over 55 are the main victims of employment crisis. And then just on and on about PPE. Black workers face two of the most, lethal pre-existing conditions, which is racism and economic inequality. And again, angle, Black essential workers are twice as likely to experience workplace retaliation. And what that means is that when Black essential workers report that, when they report that policies were not being followed when it came to COVID-19 protocol, they were more likely to face workplace retaliation and sanctions for that reporting. So there's a lot of disparities, not just in age, race, and health status, but also the employment status as well. And this is again what Mike and Constance were talking about. So the recommendations that I have in general, these are not specific to COVID-19, but just in general for supporting older people or just workers who are dealing with chronic illness while they're at work, is to come up with creative and innovative ways to better support older workers working longer, such as flexible work arrangements, such as stage retirement, such as ergonomics and other equipment and machinery that can help them do their jobs without having so much physical wear and tear on their bodies. Of course, more adherence to the American Disabilities Act, more social support programs and policies that seek to understand how racism, sexism, ableism, ageism all operate and are intersecting in experience. Number 4 is that there definitely needs to be stronger reinforcement of race, gender, and age discrimination sanctions at work. So there's often workshops and training and knowledge-based and educational series about racism, sexism, and bias, but there are no sanctions to follow up when people are accused or go through the due diligence of those accusations. And then finally, which is really important, of course, is to work with legislature to create policies to ensure economic security and safety through Social Security, retirement, and public assistance. For researchers, I also have some recommendations for you as well as far as future directions or ways that you can incorporate these ideas into your research. One is to center the experiences of Black workers to better gauge the health of the nation and the economy. Many times when we get social statistics or national statistics about the pulse of the nation, it is middle-class white Americans that are surveyed and being promoted. But Black workers are going to be, because of history of racial discrimination, economic oppression, and the things that I discussed before, they're going to have more disparate outcomes. And so really understanding the experiences, the real-time experiences of Black workers will better give us an understanding of the real state of the economy. Also, center the experiences of specifically older Black women workers. Older Black women have worked historically as caregivers, low-wage workers, but have also worked in service professional, marginal jobs, and they are also very socially mobile, one of the most socially mobile groups across our economy. So they are a great data set, if you will, to understand how to navigate at the margins. Michael said this earlier, to center the workplace as a point of analysis would be a great starting point. Fund community-based research, and then also fund and support Black health disparities researchers, because Black health disparities researchers and community-based researchers have worked for years. And now finally, because of COVID-19 and the language of the essential worker and how health all intersects, they're now getting a platform, but more funding for those who have been doing this work historically would really help push our understanding and our policy forward. So that's the end there, and then I'll turn it over to our moderator.
Thank you so much. These were great presentations. Before we start the Q&A, we want to share a survey link in the chat box. After the webinar, please share your thoughts with us. We'd love to hear from the audience how you think we can improve moving forward. So with that, we'll open this up to our audience. Please submit your questions for the presenters to the Q&A box, and I will go ahead and read them out loud for the group. So before we start with others, I had one question, Dr. Jason. Michael had discussed the hard to reach versus hardly reached populations and workers. And then I noticed that in your presentation, you talked about that your study included cashiers and housekeepers and some others. And I wondered if that concept of hardly reached resonated with you, or if you saw that limited capacity for reaching certain populations like lower wage workers, if you saw that at all when identifying study participants.
Okay, so your question was going in and out on my end. Can you just briefly say it?
Yes, I'll try. Sorry. So Michael's presentation where he talked about hard to reach versus hardly reach.
Yes.
And then your study had lower wage workers, cashiers, housekeepers. And I was just wondering if that concept resonated with you, if you saw that difficulty in identifying study participants.
Yes, thank you, thank you. So Michael and I come from the same school of thought about that approach. Definitely not framing it as a hard to reach population, as if they're running away from us as social researchers, but really, how much engagement and understanding do we have? And so with my particular study, I never approached my research design in a way that required my participants to come to me. So one thing that I actively did was built my research design in a way that went out and into the community in a way that was easily accessible by this particular group. And then building rapport and then a relationship and then being able to capture the data in the way that I did. But I really appreciate and love when Michael brought up that point, because I think it's a really simple principle in health disparities research, and it really flips not just our mentality, but how we design our research as well.
Thank you. Okay, I'll try to speak clearly. I think this was for either Constance or Michael. Is there a total worker health vulnerability assessment you recommend for workplace violence? It seems like there might be something older than 10 years old on the CDC website, but do we have anything more recent?
Do you know, Constance, I'm not familiar with any specific tools. I think the best thing to do perhaps would be to reach out directly to the Total Worker Health Office with that request with an email to someone there. Maybe Sarah, you have the, aware they can get a hold of y'all and see. But I'm not aware of it, but that's also not my area of research, so I'm sorry.
So
I would second Mike's recommendation. Go ahead, Dr. Jason.
No, go ahead. I was gonna say something different. Go.
Oh, I was just gonna say I would agree to contact the Total Worker Health Office to see if there's something more current.
I was just going to say that I really appreciate the attendee for bringing up this point, because workplace violence is a huge factor when it comes to health. The Bureau of Labor Statistics found that homicide was the #2 cause of death at the workplace, and that women are overwhelmingly the victims of workplace violence in general. So it's definitely a public health issue. And this is even outside of the context of the more recent, if you will, mass shootings that we're more familiar with, and just the long history of domestic violence on an individual and interpersonal level at work.
Thank you. That's a great point. We will put the Total Worker Health email address in the chat box as well. So anyone who has any questions about the webinar or any topic in particular, please email us and we'll get back to you. So next question. So I think this came through during Michael's presentation, but anyone could respond. Did you see disparities in worker health with regard to the impact of COVID-19? And if so, how is that being addressed? So I guess that would be within NIOSH, but even more broadly, societally, how's that being addressed?
Yeah, I can jump in and start on this one. I think there have been numerous articles that, I think there are a couple of different ways fitting with the spirit of this webinar that suggest how the relationship between, work, COVID, and health inequities have come together. One, I think you see an overrepresentation of racial and ethnic minorities and immigrant workers in essential jobs. So they, were more likely to have to actually physically go to work and less likely to be able to telework, which put many at an increased, risk of contagion. I think simultaneously, many of the individuals from those same groups were also suffered disproportionately unemployment or limited employment opportunities based on the economic shutdown that accompanied COVID as well. And so the loss of a job or loss of hours of work, for waitresses, for example, kitchen staff, et cetera, other industries that were impacted, also has a significant negative impact on health. And so I think both in terms of being disproportionately represented in the essential workforce and disproportionately represented in those who were laid off or the unemployed workforce due to COVID, both had health impacts on these in the communities that these workers come from. I think in terms of from a gender lens, I think there's been a lot of research around the double role that women had to take, particularly in terms of taking care of the schooling of their children who were staying at home and trying to work. And so I think there was it's called the She Session, for example, on how the economic impact of COVID on women workers as well. But I'll turn it over to the other panelists to see if they'd like to add anything.
Okay, no problem. Thank you, Mike. There was a question. Given the heavy health burden that smoking represents, should a preferred employer have a tobacco-free workplace policy? And would disadvantaged workers support such a policy?
I'll jump in and attempt to answer that, Sarah. A tobacco-free workplace, what could be bad about it, right? CDC properties, federal properties are all tobacco-free environments, and an employer can support a smoke-free environment with tobacco cessation programs. And for example, we have a whole campaign agency-wide around quitting smoking, but also some of our locations have turned their smoking shelters into bike shelters. So trading in one negative habit, if you will, and picking up a positive one with that space. And so that's a great policy to have, but you may include your employees in that discussion about how best to do it and get their input and feedback into what a smoke-free workplace might look like and what that might mean for them, and answer some questions before you just lay down the law and say, we're going to July 1st on June 3rd. So.
Thanks, Constance.
I'd also suggest that kind of to frame one of the points I was making in this move towards a biopsychosocial approach, away from a strictly biomedical approach to these issues. One, I think, like Constance said, it's very hard to argue against, or in favor of smoking in the workplace. So I wouldn't be advocating for that. But I think I think the question, moving towards this new paradigm is not just should or shouldn't we allow tobacco on site, but asking what is it about the work that may be contributing to stress, which may be encouraging employees to want to smoke, for example, and so, the move towards, non-standard or less secure employment arrangements, wages, the freeze, low wages, low job security, those types of work related, the way that jobs are organized and employment arrangements are organized may be contributing unduly to stress, which may be impacting employees' decisions to smoke, or may increase their difficulty in being able to not smoke, and or to quit smoking. So I'm not advocating that you shouldn't have these policies. I'm just saying maybe it would be a way of initiating a larger conversation on some of these bigger issues on how that employer is, has a relationship with their employees, and how, some of the larger questions on stress, job security, et cetera, could play into that.
Thank you. That was very helpful. Okay, question for Dr. Jason. Curious how access to transportation factored into preferred employer choice or proximity to the transportation or destination. For example, are these older workers driving themselves or relying on public transportation and the additional time that that would take?
This is an excellent question, and I think really excellent framing, thinking about how access to transportation is connected to a preferred employer. Now, I do not know the answer to that in the grander scheme as far as a study of public transportation in workplaces that have been identified as preferred employers, but it'll be a great study if it's not already out there. But what I can tell you, and why this question makes so much sense to me, is that so many of these workers that I interviewed, and even beyond the ones that I interviewed as a normal pattern of activity, is that they were carpool together. And I think that's one of the great benefits of having that consistent schedule. All of them come in at the same time. They come in these batches, come into work. And even the second batch comes in from like 2 to 11 or something in the evening. So the ability to carpool, this particular workplace is connected to a bus line and connected to a major public transportation system. And so that is another thing that would contribute to that employer, that preferred employer model. And so I think this is a really huge question, because low-wage workers, chronically low-wage workers do have transportation issues, but transportation seemed, I'm only talking to the people who were able to make it to work, they were able to overcome those factors by using public transportation and carpooling for the most part.
Okay, thank you. Perfect.
Mm-hmm.
A question, I think, for everyone. We can start with you, Dr. Jason. If you want to pass it along, that's fine. Just to get in order. This one says, how does the experience of well-being differ between, across, I guess it says between white and non-white workers? Experience of well-being, or maybe it's how it's presented, possibly.
I can take a stab at this question. It is kind of vague, so if I don't address it, please just do a follow-up. But I think in general, not just my study was just a small empirical example of a larger trend that white adults are typically in better health because they have historically higher incomes, better education, better access to healthcare, more access or higher rates of home ownership, and all of these factors that lead to a better sense of well-being. Whites also have better access to good jobs and can less likely to be in low-wage work. So like the CDC reported, Black and Hispanic people are more likely to be essential workers. What we know about essential workers are these are low-wage jobs, right? And, whites were not a part of that conversation, even though we know that there are white people in essential work. So, when you talk well-being, I think it is a fact. Health is, like Mike was saying, the social determinants of health. Health is the outcome, but it's these social determinants that whites typically have an advantage over other groups who are non-whites that give them better health outcomes, longer mortality, and less chronic illness over the life course.
I'll add to that conversation. If y'all will remember, around this time last year, we were dealing with a lot of societal issues around police brutality and things like that, several marches and protests and things like that around the country. So when you talk about your workers' well-being and people who were affected by those activities or ongoing things in their local communities, when you ask your employees when they get to work, are you okay? And it's like, no, I'm not. Like, there's this, ongoing stress, ongoing, and so the well-being of certain populations are definitely affected by the society. And I don't remember if I said it, but I meant to say it. What happens at home, reflects at work. What happens at work reflects at home. So when you're going to communities where there's turmoil and stress with the infrastructure there, and then you come to work, and people at work may or may not be on opposing sides of whatever the issue is, it's definitely affects the worker well-being.
Thank you, Constance. I appreciate that perspective. Another question that we have, how do policies that help disadvantaged workers get put into place? Which I think is a great question. So outside of research, how do you work with lawmakers, or do you work with lawmakers or policymakers, so the people who need to hear about your research know it exists? This is important work.
So I can start with how do policies get put into place? They get put into place generally by a mandate. It's usually outside pressure that puts things in place, because workplaces usually operate as business as usual, right? And the reason why they operate as business as usual, because the policies and practices that are in often are to the advantage of white people or middle-class white people, right? And so it takes effort for those who are marginalized, and this can be women, or this could be, different people of color, or, sexual orientation, or whatever the difference may be. It will take a political push, a social justice push, a push, just like we experienced with the racial uprisings of 2020, where we have all of these social justice statements, and there's a need to respond. So it's really important to connect legislature and workplace, to connect the legislature and the workplace in a way that these policies will be put into place and then hopefully implemented, because that's what I was saying before. You can have policy put into place, but if there are no sanctions or no implementation tied to them, that's a whole nother thing. The second part of this question is really a general debate about research versus policy and practice. And so, we have those who do research, and we do research, we put it in articles, and we hope that policymakers, pick it up, and that workplaces pick it up. But there are instances such as this, or what NIOSH is putting together now, where we're integrating the ideas of those who are in practice and policy, as well as researchers, to brainstorm and collaborate so that these ideas won't sit on the shelf, and that they can be put into practice quicker through implementation and other types of recommendation.
I'll chime in, Sarah, with that. On a smaller level, for example, in the NIOSH workplace or the CDC workplace as a whole, pretty much everyone, I think it was 90% of the workforce has been teleworking since March of 2020, and many people are still not physically back in the building. So some folks that are teleworking have never done this before, and have wanted to, weren't allowed to, whatever the case may be. And I think it's an easy study, if you will, to say, oh, Constance is able to work efficiently from home. So she's been asking, and we've been saying no. When we go back to the office, let's look at a policy, or let's look at how we can address folks that have allowed to work from home in our team or our group or our division, and look at how we can allow that, or at least have some leeway in terms of you do not have to come to the office 5 days a week. And so we do have a telework policy, but again, as I stated, many people were not allowed to participate in that. And so on a smaller scale, with Healthiest NIOSH, we definitely work with our leadership to sell our ideas, if you will, about what we think will improve worker well-being. And getting the buy-in and support of your leadership is very important in trying to make some changes in the workplace. If it's exercise classes and people can go during the day. It doesn't have to be before work or after work. It can be during your work day. Do you have a policy that says you can't do that? Change it. So getting the buy-in of your leadership and again, engaging your employees on how you can make change that they'll appreciate and embrace that will improve their well-being is important.
Yeah, I think just to reiterate, one of the points that I was making in the presentation is this idea of kind of expanding the view of the relationship between work and health, and work as a social location, to increase and improve the social determinants of health, whether that's through raises or sick leave or other policies. Can be a very effective way for public health professionals or researchers or labor advocates to try and integrate into movements that are occurring, whether they be legislative around labor issues like increasing the minimum wage, for example, that's been tossed around recently, to initiatives within corporations who have responded to public pressure and adapted and created offices of sustainability or corporate responsibility. To the degree that we can frame work and the relationship between work and health, gives us a vocabulary, I think, that facilitates our engaging debates around labor policy, around corporate sustainability and corporate responsibility, to kind of wedge in issues of health and improving worker conditions and worker pay and other basically the decent work agenda as almost a health intervention that can capitalize on workforce development efforts and social responsibility efforts and other efforts that are going on, to the degree that which work and health are largely absent from at this point. And so I think adopting some of that language and some of that perspective allows us to engage in these debates in areas and fields that many public health professionals and labor advocates are not engaged in currently. That being said, of course, as federal employees, at least we can't personally advocate for legislation. That's something that the research, we do the research, folks have to take that and move, do with it what they will.
Thank you. I think that's all the questions we have time for today. I want to go ahead and thank all of our speakers. This was really lovely to hear from you all today, and thank you for your time. Thank you to the audience for your time. Please continue to connect and engage with us. You can visit our website. We're on social media as well and have a quarterly newsletter. Please email twh@cdc.gov if you have any lingering questions. We will pass them on as appropriate. But thank you so much and have a great rest of your afternoon. Bye.
Thanks, everyone.
Thank you.